So pathophysiologically wise, what's going on is, like everything else in our body, our brain works on electricity, and seizures are caused by abnormal electrical impulses in the brain. They go in like kaflooey, they're all over the place. And the way we see this is first that the patient has a seizure, but if we hook them up to an EEG, we would see uncontrolled brainwave activity, and that uncontrolled brainwave activity is what we are seeing demonstrated with the patient. But I also said the other day that the big gigantic seizures that are very dramatic and that we see on TV, because they put them on TV because they are dramatic, they are not the only type of seizure that is out there in the world. So we have to be alert to other types of seizures with patients. So, some of the causative factors of seizure activity. Birth injury is probably the one that is most often blamed. But the reality is that most are idiopathic. They have no idea where they come from. Seizure disorder does run in families. It is not directly inherited. They haven't yet found a gene that says you have this gene that's going, but they do tend to run in families. And these are some of the other things that we talked about yesterday: central nervous system infections, trauma, structural lesions. A structural lesion is like a brain metastasis or a tumor. And then some metabolic disorders that can cause seizure disorder. But by and large, we don't know what causes them. And then what happens is someone says, oh, it must have been a birth injury. And in the United States, an OBGYN physician and or a midwife can be held responsible for birth injury through the age of 18, even though it doesn't show up before the age of 18. So if a child is 18 years old and develops seizure disorder, if you have a person who is very litigious, meaning they're looking for litigation, they can theoretically sue the physician that delivered that child 18 years ago, which is why OBGYNs have such enormous malpractice. Their malpractice is some of the highest in the country. It's crazy. In my mind, that's like a little bit of craziness, but that's the fact. Those are just the facts of how it is. So even though birth injury is up there, it is really, even though if you look at numbers, it might be very high, in reality it's probably not even close to what it's reported as, because it was due to lawsuits and things like that. Most of them are idiopathic. And idiopathic means what? No clue. Just all of a sudden, there we are. Okay, so there are different classifications of the different types of seizures. There are partial seizures and generalized seizures, and then there is one standing all by itself, status epilepticus, which we'll talk about. Partial seizures occur in just one part of the brain. So they're more focal. Remember yesterday I said when you had a brain injury, we really couldn't tell you, I can't tell you exactly what the symptoms are gonna be because it depends on what part of the brain. Same thing with a seizure. Depending on where that seizure is originating in the brain, it may look different than someplace else. So partial seizures are, for the most part, occurring only in one area of the brain. The simple partial seizures are generally what we would consider a mild, type seizure. I'm not sure people who have them consider them that way, but that's what the medical world believes. They are generally focal or localized with localized onset. They begin in a specific area of the brain, and the signs and symptoms are related to that area of the brain. They can spread, partial seizures can spread to become generalized. So it's almost like when one side of the brain starts having this misfiring of electricity, the other side kind of picks up on it and then starts misfiring as well. But that doesn't happen with all people with partial seizures. The simple partial seizures are primarily motor or sensory, so they can be either or. There is generally no loss of consciousness. They are generally less than a minute long. So you gotta be really astute to pick one of these up. The motor simple partial seizures are often things that they call, there's like this is called pill rolling. Like this could be a seizure. If someone all of a sudden just starts doing this, it's one little group of muscles that's being affected by whatever is going on in the brain. They could have numbness and tingling. They could have a momentary loss of vision or an alteration in their vision. It could get blurry. They could be seeing double, which is called what? Diplopia. They may have difficulty with their balance. These are all simple partial seizures. Complex partial seizures are often behavioral. So we're gonna see a change in the patient's behavior, either in their affective part of their behavior, their cognitive behavior, whether or not they can understand you, and they're emotional. They may start crying. They may start laughing. These are almost always temporal lobe seizures, so you're having the misfiring here in either the left or the right temporal lobe. They are also generally less than a minute in length. These, however, often are accompanied by what we call post-ictal confusion. Post-ictal means after the seizure. So post-ictal confusion. These can also be pill rolling. They can be automatisms. An automatism is an inappropriate repetitive movement. So it would be like, and then they just stop. There can also be distortion of visual or auditory input and vertigo that accompanies it.
Can you just repeat that last part?
The whole thing or just part of it?
The auditory part?
Oh, the auditory part is that they can sometimes have distortion of visual or auditory input. So things can sound like, you know, on Charlie Brown when they have the adults and they go wah, wah. So what they hear is they hear you, but it's distorted. And what they see is distorted. It could be like, things can become pinpoint, they can become like really wide, like panoramic. So there's a visual distortion of what they're seeing. They have to report that. There's no way you can know that. That's like a reportable symptom. And then the generalized partial seizure is the one that starts as a partial seizure in one area of the brain and then can convert into generalized. Yes?
Is that the reason why they separated the brains? The left side, the hemispheres, there's a surgery that they separate both.
Yes, if there is, yes, if you have a generalized partial seizure, they can separate the part of the brain through the middle of the, not that subtentorial, but through the membrane that's in the middle, they can separate the nerves and the axons that are communicating. It doesn't always stop the original seizure that's in the part of the brain that's actually not working, but it will stop it from jumping to the other side. So it would look more like a simple partial seizure. It doesn't always take it all away. Sometimes they can actually do surgery and remove the area of the brain, or they don't necessarily remove it. They can either kill it with radiotherapy, or they can remove it, but doing it with a scalpel, you usually take out too much good tissue. So they often use radiotherapy, and it's very targeted, and they call it surgically removed, but it's just basically killing an area. And then the seizures can either stop or at least be lessened in severity. There was, when Columbia was doing those public service announcements, really come to our hospital announcements, and they had a young woman who had seizure disorder that was completely interrupting her life, and she did have that surgery, and she could now function much better. It didn't take away all of her seizures, and you could go on Columbia's website and read about her history and stuff. It was, I thought, pretty effective marketing, but anyway. So the generalized partial seizures start in one area, move to the second area, but what we see looks like a generalized seizure because the communication is instantaneous. The only way you can tell what's happening is on EEG, because it starts someplace before it moves. But what we see physically is we see an actual tonic-clonic generalized seizure visually. So the only way to know what's happening in the brain is to do the EEGs. Generalized seizures, unlike the partial seizures, occur simultaneously on both sides of the brain. So it's bilateral misfiring of the brain. It is synchronous, meaning it's happening at the same time, as opposed to the partial generalized seizure, which happens seconds apart. There is often no aura, A-U-R-A, which we'll talk about in a minute, because the aura is thought to be a subconscious awareness that a seizure is going to be occurring. So with the partial seizures, where you only have one area of the brain that's going to be misfiring, the other area of the brain can still work and say, oops, this might be happening. Whereas in a generalized seizure, because it is bilateral and synchronous, there's no warning. Okay, so an aura is often thought of as a warning. There is often a loss of consciousness, even though it's just for a couple of seconds or minutes. And there are a couple of different kinds. So the first one that's up here is absence, not absence. Those little French people made everything sound pretty. We have absence seizures, and these also used to be called petit mal, little bad, instead of big bad, which is grand mal. These primarily occur in children. They usually disappear spontaneously around puberty. They can evolve to a different type. So a 5-year-old can start out with absence seizures and then move on to tonic-clonic seizures over time. There is generally a short loss of contact with the outside world, so they kind of stare. Sometimes it's actually called a staring seizure, where they just do this. Sometimes you all look like you're having absence seizures. But But think about it, they're primarily children. Think about being in a classroom or being the parent of a 5-year-old, and one of the most common symptoms is that they stare. Any of you know 5-year-olds? They stare all the time, they're like, "Huh, that's pretty, it's a nice butterfly." And they're out there. So, they're very, very difficult to diagnose. You have to have somebody who's very astute. You might have to have family history that would make you think that something's going on. They often don't get picked up until children are in school, because with the absence seizures, they can have up to a couple of hundred a day sometimes. And if they're lasting 30 to 60 seconds, that's 100 minutes a day that they're losing. So when they're in school and they're losing all that time, you know, they miss homework assignments, they miss what the teacher says, they don't even know about it, because they are not connected to what's going on in the classroom. So that's often when they get diagnosed. Doesn't mean they haven't had it since they were younger, it's just when they can pick it up. They often hyperventilate, and then the hyperventilation can actually make the seizure occur as well. So if they are hyperventilating, sometimes, and I know this is, well, I shouldn't say it's controversial, they still teach, we still teach, including me, that flashing lights can bring on seizure activity. And that's true not just of absence, but of the myoclonic and tonic-clonic seizures as well. That's why kids with seizure disorder are generally just not permitted or very, very limited in using video games, because the constant jumping on the screen can trigger the brain to misfire and then have a seizure. There are people who have generalized seizures who do not have that trigger. It doesn't mean it doesn't exist for other people. So it's still, you know, it's still taught and it's still experienced, even though there are some people that will say that that kind of perpetuates the negative stigma of patients with seizure disorder, that they're just gonna like drop if something is flashing in their eyes. But it does happen, so we need to be aware of it. They often have abrupt beginnings and ends, these absence seizures. And they can be as little as 10 seconds and as long as a minute. Myoclonic seizures are sudden repetitive muscle contractions, usually in one muscle group at a time. So sometimes the quads will start contracting, and it's just the quads. It's usually, again, bilateral. These are generalized seizures, so it would be bilaterally. They're often brief, and they often occur in clusters, meaning they'll happen one right after the other, and then they'll stop for a couple of days or a couple of weeks, and then it'll start again. So they occur in clusters. They don't really know why, but they do. The tonic-clonic seizure is the most again, that's the grand mal, the big bad. Again, these French make it sound pretty. The grand mal seizure, no, is what we see on TV. It's what we typically think of when we think about a seizure. It's also the most common type of seizure. There is a loss of consciousness. The body becomes stiff. That's the tonic phase. Okay, that's stiffness. And that generally lasts short period of time, 10 to 20 seconds, and then the jerking movements start. That's the clonic phase, so tonic-clonic seizures, and those can last for 30 to 40 seconds. There is often accompanying the movements of the body, there's increased salivation, which is what often led to, well, not often, which is what led to people often saying that they foamed at the mouth. They don't foam at the mouth. They produce, during the seizure, they produce extra saliva. And because there's all this contracting going on in their body, they can't swallow it. So it falls out of their mouth. They're not foaming. I promise you, there is no foaming going on. They have generally speaking, not generally speaking, they also have apnea and cyanosis for the same reason. If if all of their muscles are jerking and contracting, it includes their thoracic muscles, it includes their abdominal muscles, and they don't have the ability to get a deep, good breath. We can see circumoral cyanosis. That's usually where it shows up. And they can become incontinent of bowel and bladder. Post-ictally, so after the seizure, these patients are often drowsy, they're confused, they have amnesia, and they're extremely sore, their muscles, from the very vigorous contracting that's going on for that minute that it's occurring. Status epilepticus is something that is considered, probably the only time that seizures are considered emergent is status epilepticus. The other time that might be an emergency is the first time it happens, just because you're unaware and you don't know what's happening. That we could say is emergent. But part of the teaching that goes along with patients with seizure disorder is that you don't have to call 911 every time it happens, because it's unfortunately expected. We hope that we can get them medicated to a point where they're no longer seizing on a regular basis. They still might have breakthrough seizures, but for the most part, seizure activity is not an emergency. Now that I've said that, status epilepticus is an emergency, and regular seizures are treated as an emergency in the hospital. Anyone been at the hospital where someone's had a seizure and rapid response is called like immediately? He's seizing, call rapid response. It happens every time. So in the hospital, we treat it differently than we treat it at home, but most of these people are home with their disorder. They're not going to be in a hospital. So status epilepticus is when a seizure lasts longer than is normal for that patient, and it doesn't break. We already said that most of them at most last a minute. So when they last longer than a minute, there's gonna be an increased possibility of longer standing apnea. So we wanna make sure that we are treating this appropriately, and this is when we would call 911. If the patient were home, we would tell the family to try to get them flat on the floor, to try to just watch them, to make sure that then try to turn them if you can. All the things that you would normally do for somebody that you didn't want to choke because they had all the saliva that they're not swallowing. But the reality is there's really not a lot you can do. Because turning a patient who's jerking all over the place and trying to keep them on their side doesn't work very well, even when you're in the hospital. And when you are in the hospital, you would put a nasal cannula on the patient if you could. You may not be able to get one on them. You would certainly not be able to get a mask on them easily. So nasal cannula would be your first choice. But there's really not a lot we can do other than to be at the ready for when the seizure stops, or if it's not stopping, to give them meds to stop it. Yeah.
Would you try to suction?
You would never try to suction
Like
somebody.
the outside of it, not
No.
the actual inside?
Nada, no. You would never put anything near a patient's mouth. You can try to wipe it away if you wanna use a cloth, but you would never put anything near a patient's mouth while they were seizing, especially one's fingers. You know, in the olden days, they used to say, you know, put your hand in and try to keep the tongue forward. No, 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 no. Your fingers will be eaten off. That's how severe the contractions are of the jaws. You couldn't pry them open if you tried. Like in the olden days, when I was a brand new nurse, any patient who had brain mets or had seizure disorder or had brain cancer, I told you I worked at Sloan Kettering, so those are the things that I know. We would, hand to God, the minute they came in, we would put a sign up that said seizure precautions. Their bed would get padded, which is not a bad idea. We can still pad their beds, because as they're flailing around in the bed, you don't want them hitting their head on a metal board, or a metal side rail. So they would pad the beds, we would put the sign up, and then we would take, and I laugh about it now, but it was like just automatic. You would take a tongue depressor, you would take 4 4x4s, you'd wrap it around the top, you would tape it, and then you would tape it to the wall. Because if they seized, you were supposed to grab it from the wall and try to get it in their mouth, to keep their tongue forward. We don't put anything in their mouth anymore, because you know what happens if you actually got that thing in their mouth? They would bite down so hard, it would snap in half, and then they would puncture their upper palate. So we were not doing any good. Because most times you couldn't get it in, and if you got it in, you were causing more damage. So they finally stopped that silly stuff. But the thought was, and why did we do that? What did people say about people who have seizures? What are they gonna do?
Bite the tongue off.
Either bite their tongue off or swallow their tongue. I promise you they will not swallow their tongue. Their tongue is attached by a frenulum. We all have one, okay? They do not swallow their tongue. What happens is, post-ictally, what did I say? They become confused, they become lethargic, and everything, all of their muscles just relax to a point where the tongue gets flaccid, but they still can't swallow it. But it can, just like in an unconscious patient that we're gonna do CPR on, we want that tongue forward, right? So we jut it. So that's when you would turn the patient on their side. You might put an oral airway in. An oral airway is just a piece of plastic that has a little button that doesn't let it go through the mouth. And it's shaped like an S, and it just slips right in and it pulls the tongue forward. So post-ictally, you can put one of those in. And they often have, either down the side or down the middle, a space where you can put a suction catheter so you can suction them afterwards, but never while it's occurring. And don't put your fingers near there really, because they'll bite them off. So, but status epilepticus is a problem for patients. It's for patients who, for some reason or another, are not controlled well on their medication, and it may be because they have a fever. What happens when we have a fever? When you're taking medication, what happens when you have a fever?
You metabolize it faster.
You metabolize it faster because your whole metabolism is increased. So even though the drugs for seizure disorder tend to last longer in the body, you're still gonna metabolize them faster. And if you're kind of at the end of your dosing, you can now have a status epilepticus. It could be a new patient who hasn't been well managed yet. It may be that they've grown 4 inches because now they're beginning to get into puberty. And when they grow the 4 inches, now they need different meds. So there could be a whole bunch of different reasons. It could be because they're sick. And, you know, when we're sick and we add extra physiological stress to the body, it does stuff. So,
When you have a patient that's sick, where do you want the patient to report the fever, whatever illness that they have, so you can adjust the medication?
they're not going to adjust it for a short-term for a short-term problem. Probably not. Again, because they stay in the system for so long, and then you've got a patient that's got a short-term problem like an infection, and now you've given them a long-term problem with too much medication. But you can't, once you give it, you can't take it away. It's kinda like when you add salt to food, probably add it later, but you can't take it away. They can also develop arrhythmias if they have status epilepticus. They can become hyperthermic, again, because there's so much misfiring going on in the brain, it affects the temperature area of the brain. There can be muscle damage from the chronic contractions. So we need to understand that status epilepticus is an emergency, that in the hospital, a regular generalized seizure is often treated like a status epilepticus, even if it's not, but that's how they treat it. Okay. Now, I said before that the generalized seizures don't always have an aura. But the partial seizures do. So this is a combination of the two types of seizures in the different phases, and some may happen and some may not. Prodromal. Prodromal means something happens before. It's the prodrome to the illness. So prodromally, a patient with seizure disorder that has a seizure may have an infection, may have been playing a video game, may have all those things that I just said that could possibly initiate a seizure. That's the prodrome. Okay? They may or may not have an aura. The oral phase. If they do have an oral phase, it's most likely in the partial seizures. And an aura is something that the patient experiences, not you. You don't, and I say this for a reason, and it's often sensory. They can smell something, they can hear something, they can see something, okay? Sometimes it's a feeling, but they should know their aura. And when you teach a patient who's a new seizure patient, you should teach them and make them aware that they should pay attention to whatever triggered it, the prodrome, and whatever they might be feeling, hearing, seeing, whatever, right before the seizure. Because that's their clue. That's their body telling them that something is gonna happen. And we also need to listen. And I have a story for almost everything because I've been a nurse for so damn long, but most of it was when I was a new nurse, because I was the worst new nurse in the universe. Probably forever in the universe, I think, like from the beginning of time until now. But I turned out okay. But like all of this stuff was jumbled in my head when I left school. Like I kinda had thoughts, but they were fleeting, and they were not connected at all, none, zero. Like there was like just stuff going on up there. And I had assigned a nursing assistant to a patient who had seizure disorder, but who had not seized, but was in the history, on the admission history, which I had done, seizure disorder. And so I assigned it, the nursing assistant, and I hear this commotion, I'm like giving out meds, and I hear like fighting, like not yelling fighting, but like stern voices. And the patient is saying to the nursing assistant, I smell oranges. And the nursing assistant is saying to her, you have nothing orange on your tray. There are no oranges, there's no oranges. The patient is saying to her, no, I smell oranges. Like this should have some meaning. Before I could get there, the nursing assistant is yelling, I need help, she's seizing. And sure enough, she was seizing. So we called the troops, she stopped seizing. Her aura was she smelled citrus. That was her aura. Sometimes it was lemons, sometimes it was oranges, but that's what she smelled. The nursing assistant thought she was saying to her, she smelled oranges and she didn't want to eat her food because she didn't like them. But there were no oranges there. So there was a very big miscommunication. That was the very, very last time I ever did in admission history where I did not ask a patient who had seizure disorder what their aura was, if they had one. Do you have an aura? Oh, what is it? Because it's very consistent. It's very personal and it's very consistent. Because then, the next time I had a patient with a seizure disorder, I could say to the nursing assistant, if she says anything about oranges, could you come and get me, please? Because that's what should have happened. But the patient wasn't also communicating, but already her brain was getting jumbled. So it's not like she could say, no, I smell oranges, that's what I get when I have a seizure. The only thing she could keep saying was, I smell them, I smell them, I smell the oranges. So sometimes a little prevention and learning, right, that was a learning curve for me. I knew she had seizure disorder, I didn't think to ask. I probably knew this somewhere in the back of my brain, but never thought to ask until you need it. And then you're thinking, oh, yeah, I should have asked. So, ictal is the actual seizure. That's 30 seconds, 1 minute, whatever. Your job during a seizure is to observe and document. So you first want to call for help. Help, my patient is seizing. And then either you or another nurse takes over the role of observer and documenter. And what you want to observe are the movements synchronous, are they asynchronous? Are they bilateral, are they unilateral? Is the patient apneic? Is there circumoral cyanosis? Or is there, was the patient restrained, God forbid? Never restrain also another thing, don't ever restrain a patient with seizure disorder, because the contractions are so severe they can break an arm if they try to get, I know we don't really restrain patients anymore, we're more into diversion and all that kind of stuff, but you do still see it occasionally. And if they have seizure disorder and they are jerking, what ends up happening is they can break a bone. That's how severe the contractions are. So they shouldn't be, but if they were, that should be documented. So they're gonna document the entire event. Started at 8:02, patient was rhythmically jerking, bilaterally, asynchronous, no circumoral cyanosis noted at this time. What else? Saliva noted. Whatever, okay? And then how long it lasts, and you probably, and then sign off the note. So that's the ictal phase. Post-ictal, I already told you, for the generalized seizures, they're gonna be tired, they're gonna be lethargic, their muscles are gonna hurt. And we might wanna put like some warm packs on their muscles and just really let them sleep. Because in addition to being lethargic from the seizure, if they're in the hospital, we usually give them Valium, which also makes them like that, like, whoop, out cold. And then we usually, there's, in every hospital, for the most part, well, I shouldn't say every hospital, in every hospital I've ever worked, and there have been a few, there's always a protocol as to how often you monitor them. You're gonna monitor their vital signs, you're gonna monitor their ability to wake up, when you call them, the Glasgow Coma scale, those kinds of things. So, those are the phases of a seizure. Sometimes, if it's a severe generalized seizure, even if it only lasts for a minute, they may sleep an entire afternoon. I mean, it's like exhausting mentally and physically. So it wouldn't, don't be like surprised or scared. Diagnostic testing, you wanna do a history and physical. When you do the history and physical, you wanna make sure you ask about history, the history of seizures in the family. They will do an EEG. They will also do either a CT or an MRI to see if there are any structural lesions causing this. Is there a tumor there? Is there a blood clot? Is there a whatever? They may or may not do an X-ray. They will also want to do a lumbar puncture because they will want to make sure that there is no infection in the central nervous system. And they would look at the laboratory data that we talked about yesterday, looking for things that could be causing increased intracranial pressure and thereby causing a seizure. What position does a patient take when they have a lumbar puncture? Lateral and like fetal. Is that the only position? Who else, who do we use? Well, we don't use lumbar punctures, but who often gets their back poked with a very large needle? Pregnant women who want epidurals. And where do we put them? Over the spine? Right, hunched over a tray, because that big belly gets in the way. Same thing might be for a morbidly obese patient. If they're morbidly obese, putting them in a fetal position may not open those spaces enough. So thinking about your patient is kind of an important piece of it. So think about that kind of stuff too. Now, this is tricky. Not really tricky. Nursing management. Airway is always first, right? That is the answer on NCLEX. What do you do first? Maintain an airway. In reality, there is nothing you can do about that. You can't do anything while they're seizing. Post-ictally, you can turn them on their side, you can put an oral airway in, you can suction them, you can give them oxygen, you can do all those things. Hopefully you don't have to intubate them. But there is nothing you can do during a seizure to maintain their airway. But please don't put the wrong answer on NCLEX. Even though you know you can't do it, just answer the question the way they want you to, even though it doesn't make sense in your head. You're gonna stay with the patient, you're gonna protect the patient. Now, protecting the patient, you're protecting them from harm from this violent seizure that they're having. And not hard to do when they're in a bed, right? They're in a bed. So you can put the head of the bed up 10 to 20 degrees, that might help a little bit. You can put them flat, but then make sure that you're really watching the saliva in their mouth, because sometimes it's easier if they're flat. You want to, if you have not padded the side rails, you want to get things there that's gonna protect them from hitting the side rails, or if you have enough people, put the side rails down, so that they're not flailing and hitting it. However, patients don't always decide to have, well, they don't decide ever. The patients don't always have seizures in bed. Sometimes they have seizures when they are walking down the hallway. Sometimes they have seizures when they're sitting on the toilet. So you need to think about where your patient is and what are you going to do to keep them safe. The thing you need to remember is that you don't really move the patient, you move everything around them. You get If they're sitting in the chair and they don't think, and you can't get them to the bed, you can put them on the floor. If you put them on the floor, put a pillow under their head, because when their head is doing this on a cement floor like it's under our feet today, they're gonna have a very big problem when we finish the seizure. So stick a pillow under their head, move the bed, move the night table, move anything you've gotta do to get it out of their way. That's really all you can do to protect them. You're going to observe it, and then you're gonna document it, I already said that. Pharmacologically, we are not looking to make this go away. This is not a curative situation. This is a situation where we are going to control seizure activity. And we wanna do that so that the patient functions to their highest ability. We don't want them like spacey and zonked out all day. We want them to be able to participate in life. And we wanna do it with a minimum of side effects, because a lot of these drugs have a ton of side effects. And what you need to impress upon patients when they're first going on these meds is if they are not working for them, they should tell us. They should tell the doctor, because there are so many different drugs and combinations that they can use, that it's silly to stay on a drug that's not making their life better. We've already got a difficult situation, we wanna make it as good as we possibly can. Surgery is also an option, as we said earlier. They can either do radiosurgery and kind of burn out the area that's overfiring. They can use a scalpel and take out areas, but that usually has to take out larger areas. They can use whole brain radiation sometimes. They still call it surgery. Have any of you seen the commercial for, they talk about it for breast cancer, called CyberKnife? CyberKnife is not a knife. They call it CyberKnife surgery. CyberKnife surgery is actually radiation. And that's what they would use, something similar for the seizure disorder. I'm not going to go through this entire list. Most of this list should look somewhat familiar. We already talked about Dilaudid. Neurontin you should know pretty well, right? What else do we use Neurontin for? Pain, neurological pain. How do we define how do we distinguish neurological pain from regular pain? Anyone know? Neurological pain is burning, almost always burning. Or if someone says it feels like electricity is zinging me, that's often neurological pain. And you use much different doses for pain management than you do for seizure disorder. Okay. Valium and Ativan, we talked about already yesterday in general. Felbutol is a medication. The rest of them you should all be familiar with. Tegretol, Depakote, Depakine, Klonopin, Lamictal and Felbutol are probably the two that maybe you might not have too much familiarity with. Lamictal is an anti-seizure drug, works on the brain. And the Felbutol is one of the most common drugs being used now, but it does have a very serious side effect of aplastic anemia. And we do not know which patients will develop aplastic anemia. Aplastic anemia is when your entire bone marrow shuts down. You have nothing. You have no red cells, you have no white cells, you have no platelets, you have nothing. And the only treatment for aplastic anemia is a bone marrow transplant. So, patients on Felbutol need to be watched fairly closely for hematological side effects. Ongoing needs and interventions. We have the compliance drug regimen, which we don't call compliance anymore, what do we call it? Anyone know? Adherence. Do we know why? Because when we want somebody to comply with us, it implies power. We do not want power over our patients. We want to actually be partners with our patients. And we can't be partners with our patients if we're saying then to them, you must comply, right? Dean says to you, you must comply, you can't come to class. That's power. That's her power over you, and she's got it. We don't wanna say to a patient, if you don't do this, there are gonna be a lot of consequences. That's like a threat. And that is trying to impose my power on them. What we wanna do is we wanna switch that whole thought process and find a way to get the patient to do what they should do without threatening them, even if it's an implied threat. Because when you say to somebody, you know, if you don't do this, you're gonna have a lot of seizures and you could really get hurt and do some brain damage. That's a threat. And number one, it doesn't work with everybody, because the minute you threaten them, they're like, nope, they get their back up, I'm like, I'm not doing that. But the other thing is not really the relationship you wanna have with patients. You want them to understand and to make the decision, yeah, I should do that. They need to understand the consequences, but they don't need to be threatened with it. We want to make sure that they control their stress. So if they're a type A personality and they have seizure disorder, we might want to like send them to a self-help group to decrease their stress, or one of those things. You want to manage and avoid side effects. So in order to manage and avoid side effects, patients need to know what they are, so that they can alert us to the fact that they're happening. It also means that when we do the interview, when they come in, if you're either in the office or you're in the hospital and you're doing the med rec or whatever it is you're doing, you can say to a patient, do you have any side effects from any of the meds you take? It should be like a standard question. Because some patients have side effects and they just live with them. Other patients, the minute something is awry, they're like on the phone, I don't like this med, not making me feel good, I wanna change it. There's nothing wrong with that. They will need serum blood level monitoring for most of their seizure drugs, because as I said, they take a little bit of time to build up to a therapeutic level, but then once they get there, they stay there. So for the first couple of months, they might need a lot of blood work, but after that, it's probably pretty routine every 3 months, every 6 months. Patient teaching and guidance, we've kind of just talked about that, but teaching them how to de-stress, tell people around them that they have seizure disorder so that they know what to do and they're not frightened. Teach them about their medication and what they can do to best utilize it and to do it to the best of their ability. You know, try to find a drug that doesn't have to be taken 4 times a day. Anyone ever have to take medication 4 times a day, or even 3 times a day? You almost never take that middle dose. You take it when you get up, because you're like, oh, brush my teeth, put my med. And you take it when you go to bed. Like, oh, okay, I'm going to bed, I need that. Somewhere in the middle of the day, the rest of it just gets like, oh, I don't know. For years, they want, because I'm short, my mother had osteoporosis, they were like, I don't know, for about 1,000 years I've been on calcium. And originally they were, my practitioner said to me, I'd really like you to take it 3 times a day, it's better absorbed, blah, blah, all the things I know. I knew what was gonna happen. Every day I'd go home and my afternoon dose of calcium was sitting in my pocket. I would go to take my pants off to go to bed, and I'd take out the calcium, put it on the dresser. I would take that one in the morning, put new ones in my pocket, and I'd do the same thing the next day. I don't even tell her. She still has it written in my chart 3 times a day. I let her think I take it 3 times a day. I take it 2, because at least I'm taking it. And I may not be getting the optimal dose, but I'm getting something. And it's better than taking those calcium pills out of my pocket every day. It's the same thing with patients. When you have to do something 3 times a day, It's very, because in the middle of the day, you're busy. Who's thinking about the calcium in your pocketbook, or your pocket? Or your anti-seizure medication. Oh, I feel good, I don't need, I'll take it later. I don't have water, I don't have this. So asking patients about their day and how they function, you know, some other people, you tell my husband to do something, I have one child like that. You tell him to do something and he doesn't, no matter what it is. It's like mind-boggling to me. I have plantar fasciitis. The podiatrist said to me, you have to do exercises, you have to exercise it, and you have to ice it. My husband also had plantar fasciitis. His went away very quickly because he did what he was supposed to do. I bought the little exerciser for my foot that I'm supposed to use. It's still in the package next to my couch. I'm not good at that. It has to be convenient for me, and I have to think it's really gonna make a difference. We need to teach them about an aura alert. Remember I said that? And I must have been under stress because I put stress control twice. So, stress. These are your priority diagnoses, primarily for the patient with seizures. Ineffective airway, ineffective breathing, those should all make sense to you. Risk for injury, self-concept, and role disturbances. Those are something that we didn't really talk about much, but, well, we talked about self-concept because of what people think about people with seizure disorder. But sometimes role disturbances. Once you have a seizure, you have to, it's a reportable syndrome, I don't know, disease, whatever. It's a reportable thing. And you lose your life, you lose your driver's license. So now, let's say you are a delivery person for Amazon. You no longer can deliver Amazon because you don't have a driver's license anymore. So your role is gonna have to change. You have to be seizure-free for 1 year in the state of New Jersey before they will give you back your license. If you're a child, you can't get your license. Now, when you live in the city, you're hopping on a bus, you're hopping on a train, you're hopping, whatever. You live out here and you're 16 and you don't have your license, you don't have your permit and your license, and everyone's walking around, oh my God, my permit, and you have nothing. It's very disturbing to that child. Well, it can be, it depends on the child, but for most children, when other children are reaching milestones and they can't reach them, it's upsetting. I failed my first driver's test, and all my friends got their license, and I didn't. Because not only did I hit the curb when I parallel parked, because I lived in the city, and you actually drove on the streets, and you had to park between two real cars, not cones, in the middle of a parking lot that was like so big you couldn't fit a four-wheel truck. No, I had to drive around the streets of the city and find a parking spot and park in it. So I didn't just hit the curb, I went on the curb, and then came off the curb. And he said to me, just drive back to the office. I was crushed. All my friends already had their license. And I was the only nut who failed the test. Like, I don't understand. I didn't tell anybody for like weeks. I didn't tell them. I told them I didn't take the test because I didn't want to admit it. So imagine being a 16-year-old and you're not allowed to even think about taking a test because kids tend to be less controllable, their seizures. So role disturbances.